At the outset, let me thank Dr. Sampath for giving me this opportunity to express my views on orbital imaging in orbital surgeon's perspective. No financial interest. We have imaging modalities now, number of them: plain radiographs, CT scan, MRI, ultrasonograph, and positron imaging tomography, known as PET scan. Of course, the CT scan and magnetic MRI will become the mainstay of the imaging. Plain radiographs, they essentially they show up the skeletal imaging modality and their poor tissue definition, soft tissue definition. Information which we get compared to the newer modalities is very inadequate, and the target tissue radiation is very high. That's why it's no wonder that it's not a preferred modality today, almost has been replaced by CT scan. CT scan, it's important to remember that it highlights the calcific tissue maximally, soft tissue to an extent. With contrast, it can also show us the target tissue vascularity. It can give you information about the vascular anomalies, but it cannot give us information about the blood flow. Modern CT scans are multi-slice high-resolution CT scanners. They give 1 to 2 millimeter sections of orbital pathologies. They give adequate information about the bony cage as well as the soft tissues. 3D image reconstruction gives us a better orientation of the tissue. Contrast CT provides information regarding the vascularity of the target tissue. And in given case of AV malformation, CT angio is an important tool in our orbital imaging. MRI, on the other hand, highlights soft tissues maximally, be it orbital, be it neural or vascular, with information on tissue characteristics as well. But it is poor delineating the calcific tissues. So it does not delineate the bone well. Can demonstrate vascular malformations, but again it cannot depict vascular flow pattern. Ultrasound has a limited role in orbital lesions. It is useful to evaluate anterior orbital lesions. It can measure extraocular muscle belly and tendon thickness, and that's how it can differentiate thyroid irises from shoulder tumors. It can assess the treatment response, but to my belief, posterior orbital lesions are difficult to assess. Doppler imaging is a good tool to assess the flow pattern in AV malformations. One can detect the high flow from the low flow fistulas. When the superior ophthalmic vein is found enlarged, one can detect the reversal of blood flow pattern, which is indicative of CCF. So this is a very important tool when you assess these conditions. PET scan is a nuclear medicine imaging technique. It utilizes a radioactive tracer injected in the body. The actively growing cancer cells use the tracer material chemical differently than the normal cells, hence they are detected. And when combined with CT scan, CT scan locates these abnormal pathological cells and is well documented, including the size, shape, extent of the growth. And that's why it is used to evaluate systemic spread of the malignant neoplasms and evaluate treatment response. Now, common clinical situations where an orbital surgeon needs to utilize these techniques are trauma, intraocular foreign bodies, mass lesions, infections, inflammations, and vascular malformations. The choice of modality, therefore, depends on the target tissue of interest, whether one is interested in the bone structure, whether one is interested in the soft tissues, bone and soft tissues together, vascular malformations, or an arterial venous malformations. Trauma. In case of trauma, one wants to know what is the nature and type and extent of the injury of orbital walls. One wants to know whether there is any entrapment of soft tissue, like muscle seam or an orbital fat in the fracture line. One also wants to know whether there is any foreign body there. If it is there, where it is localized. What is this depth, whether it is metallic or non-metallic. One wants to also know whether there is any orbital hemorrhage. and if it is there, whether it is the intracausal space or the subperiosteal space. Because this will help us to find out the visual loss. In optic nerve, in case of visual loss, one has to look for bone fragment compression of the optic nerve in the canal, or one has to look for the optic nerve sheath hemorrhage. There is no better modality than CT for demonstration of wall fractures. CT provides adequate information for management. MRI, on the other hand, is contraindicated in road traffic accidents, which are very common, wherein metallic foreign bodies are suspected. In optic nerve dysfunctions, CT and MRI can be used together simultaneously. CT can show us the bone fragment compression, whereas MRI always able to clearly show us the sheath hemorrhage, the differentiation helps you in proper management and visual prognosis. In mass lesions, the aim of imaging, to my mind, is the anatomical location of a mass lesion is the primary aim and not the pathological nature of the disease. CT provides adequate information for its management. In mass lesion, for mass lesion, one has to evaluate the soft tissue window, one has to evaluate the bone window, one has to evaluate the post-contrast target tissue Hans per unit value, which are calculated by the machine itself. In soft tissue window, one has to look for axial, sagittal and coronal sections, each has its importance. Bone window has to be seen for osteolysis, bone molding or destruction. And post-contrast target tissue Hans per unit, one has to look for the difference in pre and post-contrast valuation. If it is less than 20 or more than 20. Less than 20 denotes a benign lesion, more than 20 denotes a malignant lesion. Axial scan is a basic scan passing from the optic canal. It gives you idea about the presence of pathology. It tells you about the tissue involved. It tells you about the extent of the lesion. Sagittal reconstruction, besides information about the size, shape, extent and depth of the lesions, it gives you demonstrated relationship of the lesion with anatomical spaces, whether the lesion is in the subperiosteal space, whether it is the peripheral cervical space, whether it is in the central cervical space, or whether the foreign body is deep down in the orbit. So it can clearly show us the depth of the lesion. Coronal reconstruction, on the other hand, it helps to plan us surgical incisions for orbital exploration, depending upon where the lesion is. Whether one has to go for superior orbitotomy or inferior lead swinging approach, medial orbitotomy or lateral. I always consider coronal view as a clinician's view because it helps planning our surgical approach. Look at this sagittal section. There is a foreign body there, but we don't know where it is and how to approach it. And look at the coronal section. Once we have the coronal section, we know that the foreign body is in the inferior quadrant, the lateral quadrant, and one can easily remove it. Orbital infections are common in extreme age groups. Paranasal sinuses are the main culprit. In babies, usually the equine sinus is getting involved. In elderly age, the frontal sinus are common. Occasionally, in babies, especially immunocompromised babies, one can find a metastatic infection giving rise to orbital cellulitis and orbital abscesses. CT gives you idea about the source, extent, and the tissue plates involved of the disease. MRI has no additional advantage unless when one thinks about coronal sinus thrombosis is suspected. So if the carrot of this sinus thrombosis is suspected, then the MRI is really useful. Inflammation, orbital inflammation can be in the form of hidradenitis, idiopathic inflammations, or thyroid disease. There is a uniform enhancement with receptor edema seen on CT, whether the hidradenitis is unilateral, bilateral, symmetrical, or asymmetrical. So one can pick up a hidradenitis also. Idiopathic inflammation, one can see enlarged belly as well as the tendon, which is very clearly seen even on CT. And thyroid eye disease, one can see a belly involvement predominantly and not the tendon. So one can differentiate this on CT. However, idiopathic orbital inflammation, MRI has an edge over CT in picking up early soft tissue changes like fat strengthening. But by and large, CT MRI is complementary, and biopsy and interval serological studies ultimately confirm medical liability. In bone orbital studies, one has to look for osteolysis, which is seen in eosinophilic granulomas and meningiomas. If you see bone molding or bone destruction, it could be lacrimal carcinoma or osteoid carcinoma, lacrimal mass lesions. And if it's a new bone formation, one has to look for osteosarcoma and meningioma. So it gives you some guideline as regards the pathology involved. In vascular malformations associated with pulse-type proptosis, which are following post-traumatic or spontaneous dural fistulas, high-resolution CT with CT angio is diagnostic and therefore a modality for evaluation. The CT has become, therefore, a primary imaging modality in all our entities. Can I take 5 minutes? Can I? Okay. We can get all relevant information, size, shape, extent, depth, and minimal target tissue radiation. So that's why this is my preferred modality. And it is more very economical, considering the other modalities. MRI, there are definite indications for lacrimal gland epithelial tumors, cavernous hemangioma, optic schwannoma, and optical meningioma. There is already a diagnostic dilemma in benign conditions of lacrimal gland as well as epithelial tumors. However, it is very difficult to differentiate each specific disease on the basis of image characteristics alone due to intrinsic similarities. One can identify epithelitis by clinical features on CT, where you can see the soft tissue edema as well as the eyelid swelling and uveitis. One can see unilateral enlargement with surrounding inflammation, and there it could be a idiopathic inflammation. One can suspect bilateral lymphoma in a case where there is a bilateral enlargement of the gland with surrounding closed infiltration. One can pick up a pleomorphic adenoma because of the bone molding which we see in pleomorphic adenomas, but one should note that there is no bone destruction there. Bone destruction when present or when we see best seen on CT, whereas perineural and dural invasions are best seen on MRI. And these are clearly the signs of adenosystic carcinoma. And therefore, in imaging in lacrimal gland lesions, not only depend on history but on CT features as well. If you see circumscribed lesions, infiltration lesions surrounding the globe, if you see bone enlargement and bone remodeling, it's a benign lesion. Whereas epithelial tumors have benign bone destruction, perineural invasion, extraorbital spread, and one needs to do CT plus MRI. Diagnostic biopsy is contraindicated. That is why the whole exercise is necessary. Hemangioma and schwannomas can be very well differentiated on CT and MRI. Contrast enhancement spreading pattern on dynamic MRI is diagnostic. Hemangioma start the enhancement from one point or one portion and then spread over. Whereas schwannomas, they spread right from a wide area. This is the differentiating point. The importance is that hemangiomas could be cryoextracted with ease and comfort. Schwannomas cannot. So orbital surgeon's role therefore is to repair the trauma, evaluate the mass lesions and orbital infections and inflammations, remove circumscribed mass lesions in foreign bodies and cases where there is an infiltrating or expanding lesion. I believe that selection of imaging modality plays a vital role in managing orbital pathologies. And if you have to play blind, go for CT. Thank you very much.